Hi, thank you, David. Before I get into my presentation, this process that Windsor Regional is going through with the community is really groundbreaking, and there's no pun intended there with the site selection at all, but it's redefining how decisions are made with respect to building infrastructure for healthcare. That the model that they've employed with, starting with Dave Cook getting out into the community and checking the community's feelings for, do we need a new acute site? Should we move forward? That really informed the ministry and the LHIN that this was a go. To have the leadership at the two hospitals from a governance perspective come together so fast with their staff to say, we can develop a better model of care for our community, groundbreaking, where other parts of the province have contacted us to ask us for the terms of reference on what did they do and how did they do it and who led it. So it's really exciting news, and it's the power of that leadership that I believe will get this hospital built. So Sandra Livrier, I have her name on this presentation. I'm going to do the talking. Sandra Livrier is really our feet on the ground, working with all the stakeholders in the hospitals to move this project along. The LHIN's role is that the ministry has devolved the responsibility for capital planning to us. And what that means is that our board has to approve this entire process and every step along the way. Now, that fits right into the wheelhouse of why LHINs are here. This responsibility was devolved to the LHINs because decisions need to be made as close as possible to those people that are being affected by it. You have a better view of Windsor when you live here than if you were downtown Toronto. So it's in our wheelhouse. I always say the good news is we're here and we can't hide. So I'm looking forward to this. Our vision is very simple. You know, we want better care, better experiences, and better value. We're all taxpayers. We're all after constantly improving care, and David talked about that, what his organization is going through to do that. From an experience perspective, this is where my phone rings. People talk to me about the experience they had, and it usually happens when the transitions of care, when they're moving from one organization to another, and the ball's dropped or it's not that well coordinated, which I'll talk to later, and better value for money. It's very expensive, our healthcare system, 46 cents on the dollar for our tax dollar, and our costs are increasing all the time because we're constantly improving. So I'm going to talk about the community capacity plan. So what David talked about is very important, a new acute site. And hospitals, most of us in this room are going to spend more time in a hospital visiting family and friends than we're ever going to spend in a hospital. If you are admitted, usually you're in there for 5 or 6 days. They fix you and they move you out to the community to get better. So this is part of the conversation that we're having now is, what's in the community to make it better, to make you better? What else is needed there to give you greater access to services? So we have to decide that now. And David talked about a good example, the robotic arm for prostate cancer. Years ago, not too long ago, 10 years ago, you'd be in the hospital for 5 or 6 days. That's changed now to less than 2 days. That increases capacity, improves quality. Changes like that, we need to plan for the future. This hospital, we hope, will be built within 7 years or so, but it's got to last 20, 30, 40, 50 years, and you have to anticipate what services will be in that hospital, but more important, what services are going to be in the community. The community capacity plan, as I said, is really to ensure that everything is coordinated in the community to ensure that the best care is provided when you leave that acute institution. And also to ensure that the acute site has what it needs to perform. And that when the patients leave, the same level of care is continued in the community. So we have a process. We put a committee together of community members that provide our various stakeholders, and it's chaired by the CEO of the CCAC, and it's co-chaired by the CEO of the Alzheimer's Society. 2 strong leaders in the community to help lead a group through this planning process. We will be hiring a consultant to assist us, and why, you'll say, why a consultant? You're the LIN, you have all these health professionals. Because you need specialists who do this. You need specialists that do this type of work, not only in Ontario and in Canada, but around the world, because they're going to give us the best ideas that are out there. We looked at, this committee had over 50 different procedures or processes or programs that they wanted to look at that could be managed in the community to provide better care in the longer term. That was boiled down to this list of 11. And I'll just give you some examples that may resonate with you. For those of you that have had to go to a hospital for cancer treatment, there's new developments now for low-risk patients where you can receive your treatment at home. What that means is you don't have to arrange that drive from a family member. You don't have to rely on public transit, be it if you live in a city or in the county. And you can have it in the comfort of your home, and the professionals will come to you. That's very important. For those of you that have had surgery and had to go to the hospital for your workup, that can be done in a satellite location off campus. It does not need to be in a hospital. It can be in your community for that workup. Dialysis. Today there's dialysis happening in retail malls. And I look at a lot of our hospitals, they have reserved parking for dialysis patients up front, but they still have to walk over snow and snowbanks. And now they're in strip malls in Ontario, elsewhere, and around the world. So how do we plan for that? How do we ensure that we have the right capacity in the community to make that work? Emergency visits, David mentioned 140,000. That's significant. You cannot have that at one site. It is impossible to provide the quality of care and the response time when you have those volumes. We will need an urgent care center somewhere in our community to satisfy those low acuity needs. People will show up to have their stitches removed. People will sprain an ankle at a baseball game. They don't necessarily have to go to an acute site to have that work done. They need more of an urgent care center, and David will talk about that. So these are a few of the examples that we really need to work through. We need to ensure that we have the best practices and we are building the capacity in the community. Because the last thing you want to do is build a hospital and all these assumptions. Oh, when they leave here, they'll have that service. And if the service isn't there, they're going to spin back within 7 days back into the hospital. And that's why this is so important. Just remember, your average length of stay is 6 or 7 days in a hospital. The rest of the time for your care, you're in the community. And that's why it's so important for us to ensure that that's there. So an example of how we wrap around the service, you'll see the new acute site here and how they really have to interface and have the patient flow really tight with our subacute, so that once you have your hip done, on day 3 you should be able to leave and go into rehab, either into the community or into a subacute site. Might be sites in your neighborhood that you can go to. We call them a satellite site, or it might be something else. That the purpose of the acute site is to fix you and move you out to someone to get you better. And I'm going to steal a line that I heard a couple of days ago, and get your life back together. And that's the importance of having community capacity. Wrapping around there are some of our social services, the Community Care Access Center, the CMHA, the CHC. These are all services that people need once they leave an acute site to provide that wraparound care. It finishes with primary care. Now, I'm the first one to say we need a lot of primary care reform. We need to ensure that we can transform our primary care network to ensure that we have access when we need it, that the patients can see their primary care doctors rather than going to an emergency room and waiting for a couple of hours to have a small ailment fixed. All this is transformation. This takes time. But the beautiful thing about this is, and our board recognizes it, you cannot plan an acute site unless we have the capacity in the community identified and we put investments there to make it happen. And so, although the timing process for the acute site is longer, we are going to go lockstep with our planning processes to build the capacity in the community. So our next steps. We're going to continue the work that we're doing. We're actually doing an RFP for our consultant this month. The consultant will come in and we'll have consultations with stakeholders and professionals throughout the system and the public. And with the goal to, oh, I'm going on the next slide already. With the goal of, after the community engagement, is to come back next year with a community capacity plan. That community capacity plan will then need to be costed out, and we'll go through the process of approving that as we go through the various steps for the acute site as well. This goes back to you. Thank you.